submit questions. If I could just get a little wave. Everyone's good at knowing how to put in their questions. Okay. We want to be able to respond to what you want to know. So that chat bar is an important line of communication. So let's see. Oh, I see Dr. Subramanian here as well. Okay, I think that covers all our housekeeping items, and we're right at the top of the hour. So on behalf of PMD Alliance, welcome everyone. Thank you so much for joining us from your corner of the world here in Zoom land. It's so great to welcome our host, Dr. Subramanian, and our guest, Dr. Michael Okun. And I'll turn it over to you, Dr. Subramanian, to get things started.
Great, thank you. Welcome everyone. So great to see everyone in virtual support group land. Thanks, Michael, for joining us. It's a real pleasure to have you on today. And thanks PMD Alliance for hosting. We have Michael Okun, who is an amazing force in the Parkinson's world. He's just been such an amazing patient advocate, just so amazing to follow his career and get to know him as a friend. He's written other books before, including one that's been translated into a number of languages called Parkinson's Treatment, 10 Secrets to a Happier Life. He's the executive director at the Norman Fixel Institute for Neurological Diseases at the University of Florida Health, and he's also chair and professor of the Department of Neurology. And he's done so many amazing things, including writing this new book that we're going to be highlighting through a series of speakers. We had Ray Dorsey on earlier this past week, and we'll have Boss Blom, who's one of his co-authors as well. So I don't know, Mike, maybe you could just speak a little bit about what made you be interested in writing this book in the first place, and talk a little bit about the book, and then maybe we can jump into some questions. I have some interesting questions that will hopefully drive a discussion, and you and I have no shortage of topics that we could talk on over possibly hours of this sort of venue. So wanted to definitely get to any key points that you wanted to make around the book, and why you got interested in that.
Well, first, thank you for having me. I know everybody is really struggling, at home, and cabin fever is high, but we always say better to have cabin fever than to have corona fever. So if you're staying home and you don't have cabin fever, then you're doing something wrong. And so cabin fever is a good sign. So, so we're glad to have everybody on Zoom, and it's an honor to be invited. And as Dr. Subramanian said, we've been friends for a long time, and a great fan of her work and the group at UCLA. And so it's a pleasure to be with you today. We did recently write a book, and it's co-authored by Ray Dorsey, who many of you know is an expert on telehealth and telemedicine. And also there's a very nice part of the book that's written by Bastian Bloem, who's an expert from Nijmegen in the Netherlands. And Bas is an expert on gait disorders, but also on building networks of PD care. And he's built, arguably the best network in the world. And that is in the Netherlands. And it's a program called PDNet, or NetPD. And then there's Todd Scherer, who's the CEO of the Michael J. Fox Foundation, who started his career, actually, we were at Emory at the same time. He worked for Tim Greenemeyer. I worked for Malin DeLong, and he worked on pesticides. And so he brought a lot of really interesting science, and has a really interesting career too with the Michael J. Fox Foundation. And so we got together and began researching the book, and the research really uncovered a lot of important aspects. And one of the aspects that it uncovered for us was this idea of what would it take to end a disease. And so we studied polio and the March of Dimes, and we studied HIV and how they occupied the FDA building, and they were charismatic and they were aggressive, and how they increased their funding to $3 billion a year. We studied breast cancer. So we tell these stories, and within the book, it is sort of an interesting read, or I think it's an interesting read, and it really is the story of where we need to go in Parkinson. And we really come to the conclusion that we need a Parkinson Pact. And so that's why we do a lot of this hashtag Parkinson Pact stuff on social media. And the idea is we need to prevent, advocate, care, and treat. Those are the letters, PACT. And we now have the most rapidly expanding or the most rapidly growing neurodegenerative disease, and actually the most rapidly growing neurological disease. We don't know why, but it's even growing more rapidly at a more rapid pace than Alzheimer's. And so we need to do something. And so the book is sort of if you're a musician, it sort of comes up and crescendos up and tells that story of where we need to go. And certainly I would say and do that we need to be more aggressive. We need to be more charismatic. We need to get out there and really push on all areas and in multiple domains if we're going to push this disease. And so I encourage the read, and hopefully you enjoy it, and feel free to leave us some reviews up on Amazon. We'd love to hear from you.
Absolutely. Well, it's so topical. Honestly, I was reading it over the Easter weekend, and in the midst of this global pandemic that we're in, you really have done a beautiful, like you said, sort of upway sort of building of the sort of need to care about this in a way as a pandemic. And you define pandemic. Dr. Fauci's quotes are in there. You really hearken to sort of the start of the understanding of, the cases that we were seeing with AIDS. And I think both of us are old enough to have been in medicine just sort of at that time. And it was just such an interesting time frame to be in, where we were really just realizing that this was not just a local problem, not just affecting a few patients, but really, an international, crisis. And I think that you've really built a case for feeling that way about Parkinson's. And I was just really sort of shocked in some ways to look at the numbers as you crunch them, and some of the statistics as you've outlined them. And then also, heartened by hopefully the message of hope and, leading the cause in many ways as you guys are doing it. And so happy to try to be part of that in whatever way. If I can bring some charisma or some aggressiveness, whatever, I can bring to this, I'd love to help. I wanted to just highlight a few things that I found kind of interesting. And for those of you who don't have the book yet, it is available on Amazon, and we can certainly put some links on at the end of this. And we always share links that are helpful. And so Mike, maybe at the end of this, you can give us any sort of links that you think would be helpful, not only about the book, but also anything from your guys' websites that can help people in their homes and understand sort of this disease. One of the quotes that I was kind of shocked about, so you say in 2019 alone, 60,000 individuals, or over 1,000 Americans per week, were diagnosed with Parkinson's. You go on to say by 2030, there will be a 10% higher risk of a 45-year-old individual eventually developing Parkinson's than there is today. And so these are quite alarming numbers. And I think you do mention about, your thoughts as a group on the pesticides and things like that. There's always been a chat about the fact that the population in general is aging, and that we're going to see this more just because people are living longer and there's this aging population. But really what I was struck by is sort of just the sense that even younger people, even in every part of the world, are going to need to care about this disease, and that we really need to push to identify cases earlier, and figure out what's causing this global pandemic. As we're talking even in the COVID era, and figure out how to prevent this from happening. So can you speak to why you think this is happening in younger patients and we're seeing it more?
Yes. So this is a really alarming group of statistics and data. And let me say that going into the writing of the book, I wasn't an expert on this type of data, and I've seen obviously a number of these things and read a lot of studies. And so I didn't go into this with some sort of bias, like this is where I wanted to see the data end up. This is how we wanted to present it. And, so this is a group of 4 scientists, and we really looked at this and scoured this data. And what's, maybe even more alarming about it is that if you've been in the Parkinson field for a while, you know that people will tell you things like, you know, age is the biggest risk factor for degenerative diseases like Parkinson, right? So the longer we, you know, help people to live, the more chance that they have to come down with a neurodegenerative condition like Parkinson disease, right? Male is a bigger risk factor. And so we know this, and we know that populations are growing, right? And so we know around the world, the populations are getting bigger and the number of people on planet Earth are growing. But if you actually take those things into account, I guess what's startling for me is that if you take those things and you account for them, it still is not accounting for this large and rapid growth in the disease. And so, you know, one can speculate as to, you know, like why that is. Could it be genetics? Could it be the environment? Could it be something else? You know, it turns out that until the 1800s, until the 19th century, we really hadn't industrialized. And now with the industrialization of America, we talk about that and the number of cases that may be related to industrialization. And now there's literally dozens upon dozens of studies that show links to environmental things, pesticides, weed killers, all sorts of things that we use every day. Paraquat, it's been banned in over 30 countries, but not in the United States. You know, things that if we took bets in Vegas, the odds ratios are really good. We'd win those bets, you know, that these have some relationship to Parkinson's disease. And so this is quite alarming, and the growth. And the other statistic that's alarming is that over our lifetimes, you know, there's going to be a cumulative risk that Ray Dorsey has calculated of about 1 in 15. So let's say you were in a classroom of 30 when you grew up, okay? So that means that 2 of you, you know, think of all the people that were in your 6th grade class or 8th grade class, that, you know, 2 of you are gonna get Parkinson's disease within a lifetime, 2 or more. So that's a pretty startling statistic as well, but we don't have the information that would suggest that this is just an age-related growth curve. The other thing that you mentioned that's interesting is the word pandemic. And the word pandemic comes from Greek. And pan means all, and demos means people. So all people, all continents. And so one of the things that we talked about when we were writing the book is we bantered around this term, the Parkinson pandemic, which showed up a number of years ago in that 10 Secrets book, or one of the books that I wrote for patients. And the idea wasn't to stir a controversy. Is Parkinson a pandemic or not? Certainly the World Health Organization has rightly taken this word and turned it into something associated with infectious diseases. But if you look at Merriam-Webster's in the dictionary, it's not, you know, an exclusive word that's only for infectious diseases. But I think it's reasonable in the public domain to try to leave it there. But the points that we wanted to make about that are that it's in all countries, all people, all cultures, all diversities, and it's the most rapidly growing neurological disorder. And if it continues to grow at this rate, it's going to bankrupt many of the healthcare systems, including the one that we have in the United States. And so I think it's alarming. And so whether you use the word pandemic or not, I don't think we want to get into that controversy, but I think we'll agree that the general premise of what that word means could be applied to a degenerative disease.
Yeah. Well, I think the read was also just fascinating to me. I'm interested in history and the history of medicine and the history of these sorts of things. And I'm kind of a nerd in that way. And so it's just interesting to learn about, you know, why the March of Dimes is called the March of Dimes. It was actually because people were mailing in. I didn't know all of these little finer points. And so I think it's just a fascinating kind of read, and to make the parallels between these other disease states is really interesting.
Yeah, it also helps, by the way, if your disease is championed by your president. So in March of Dimes, it was championed by Franklin Delano Roosevelt, who championed that and started the disease and all those dimes being mailed into the White House. It was an effort. And, you know, if you look back and, you know, and you look at some of the quotes that we give in the book, in the height of the polio epidemic in 1951 or 52, you know, there were like 50 52,000 people with polio. And this was incredibly troublesome to the American public. And they went into social isolation, much like what we're in right now as we're talking with the Corona pandemic. And they closed swimming pools, and they closed public areas, and they closed restaurants. And nothing was feared more in the early 1950s than polio. There was only one thing that was feared more than polio, and that was nuclear war. And so if that gives you a sense, and now if you look at the size of Corona versus the size of polio and what's going on with the deaths, and you know, we're in something real here. There's something real going on.
Absolutely. Well, the mention of the you know, the toll on the economy and the populations that are affected is quite interesting to me. As you know, I think you and I both love to practice in this field and love the patients first and foremost, but I work at a VA and love serving that population, and have been, you know, hopefully an advocate for populations that may not be able to be accessing care as you know, the wealthier folks in certain parts of the world. So there's a quote that I wanted to mention here and highlight a few populations, and maybe we can talk about those. So you say that the United States spends 40% more on healthcare per person than any other country. And then you pose the question, what are we paying for if almost half of our seniors with neurological diseases do not see a neurologist? And you then go on to say African Americans, women, and the elderly with Parkinson's are even less likely to see a neurologist, which is kind of horrifying, actually, when you think about it. And I've actually been really, you know, drawn to some of these statistics myself. And you actually point out that among 8,400 individuals who've been treated with deep brain surgery, deep brain stimulation for Parkinson's, only 88, so that's 1%, were African American. And so I think that, you know, we're highlighting just in the coronavirus situation some of the disparities in our healthcare system, and how certain populations, certainly African Americans, Latinos, are not accessing care and getting sicker from this virus. Similarly, so it appears that African Americans are really in a disparate group, and additionally, women, I feel like, are really not accessing care in this sort of Parkinson's universe. And I think that there are a few reasons for that. I know the Parkinson's Foundation has been spending some time trying to understand that more, but maybe we could speak to those two populations and see, you know, maybe what your thoughts are.
Yeah, so yeah, the statistics are, you know, absolutely stunning, you know, and so all four authors stand, you know, firmly by the statement, you know, like, what are we paying for in our healthcare? You know, I mean, so everybody on this call either has Parkinson's disease or knows somebody that's affected by Parkinson's disease or is dedicated to this effort, and over 1 million Americans have this disease. And so if we look at it from that perspective, the fact that we can't get neurologist care to Parkinson, and we have the data that shows that if you see a neurologist, you have a decreased risk of morbidity, mortality, and nursing home placement. It'll save the healthcare system money. And so it's counterintuitive, but as you know, a lot of things that don't follow logic end up lost in a bureaucracy. And so I think it's another reason why the A in PACT, prevent, advocate, care, and treat, we have to advocate, and we have to point this out, that there's data that's there. You know, the data on the underserved communities is even worse. I mean, the slope just falls off, and when you look at it, it's disappointing, it's tragic, it's horrifying, you know, to see that and to see it consistently. And so when we see something in one paper, as scientists, you and I both know that, you know, one paper is one paper, but when you see it over and over and over again, and then we see it in the experience of our clinics that we're not reaching underserved populations in appropriate ways, it's disturbing, and it calls for action. And you know, we shouldn't sit back, and we should do more. There's no reason why, in the era that we're in, with so many exciting things that are going on in Parkinson's disease, with, you know, dozens of different treatments and all sorts of things in everybody's lab, and we're percolating up all sorts of stuff, and we doing a better and better job every day of treating people. That's the C, caring for patients, and then also the T, developing the treatments. There's no reason why we shouldn't be engaged more with underserved populations to make sure that they're getting the treatment. So we're developing all these things, they're not getting them, and that's not right. And so, I started off the call saying, that we studied the other diseases, and when you look at the other diseases, polio, HIV, various cancers, breast cancer, people are way more aggressive, they're way more charismatic, they're way more pushy, and so, I kind of want to be edgy and challenge everybody on this call and everybody around to push harder. It's time. We've got to make our voices heard a little more or a lot more in order to address these really critical issues.
Absolutely. And not only have we shown that seeing a neurologist actually can help with the outcomes, but we've even shown that seeing a Parkinson's, specialist or a movement disorder person can actually improve things. So it just, we spend a lot of time in our academic centers teaching people just the basics about Parkinson's in a neurology community. And a lot of what I've been spending my time and energy doing is actually teaching geriatricians, primary care doctors, nurse practitioners, whoever will listen to me
Right.
about Parkinson's, long-term care providers, because the reality is that we can train as many fellows as we want, and that's going to reach out to some percentage of patients, but that 50% of, Parkinson's patients in our country are not served by even a neurologist, let alone, a movement disorder expert. So I think we have to think about ways to get this network better in place, and maybe some of Boss's group where we're training providers about, in their specialty, like physical therapists, about Parkinson's, so they can better kind of outreach to these populations might be a possibility, or some other mechanism that we could really kind of outreach to our patients.
Yeah, and I think that your points are really spot on. I'll remind everybody that if you go see a cardiologist, or you go see a nephrologist, a kidney doctor, a cardiologist, a heart doctor, a GI doctor for your gut, these are people that, Medicare actually puts money in to make sure that we train enough heart doctors, and we train enough kidney doctors, we train enough GI doctors and other doctors too. But Medicare doesn't put any money into the training of Alzheimer's physicians and Parkinson physicians and people to take care of neurodegenerative diseases, although neurodegenerative diseases are what's leading, to the disability in our population. And so it's really striking to me. And so there's about 40 slots or so that get filled every year for people to train, and they decide they're going to train after they've done a college, right? So 4 years of college, and they do 4 years of medical school, right? And they do 4 years of residency to be a neurologist, right? They're going to do 2 more years to be a Parkinson neurologist. And that's a lot of years. And the 2 years that they do that, they're giving up, a lot of income, and they usually have accrued a lot of debt that they need to start paying back. And the centers that take them on are heroes. I mean, they're finding the money for them to train. I mean, it's not like there's any money there. So they have to find grants, and they put them to work doing research, and they just figure out ways. And these people press the pause button on their life to go in and become Parkinson specialists. And so, these are heroes, the people that are doing this work, but there aren't that many of them. And there's no way they're going to scale to the growth, the curve. And these growth curves that are going up to 2040 are incredible. So we have to start training more people, family doctors, general physicians, geriatricians. We hired our first geriatrician in the Fixell Institute that I work at the University of Florida. We're now part of their training program. I just think what you said, Dr. Subramanian, is really super important for people to keep the perspective here that, you talk to anybody that'll listen, and you rattle them and shake them a little bit. So social isolation, I don't know how you shake them now, but you got to shake things up a little bit, and we need to do a better job of figuring out how we're going to reach these populations. And certainly the government and the bureaucracy isn't giving us a lot of help in that respect. But, I always say, here at UF, when it comes to people, sometimes you you depend on the bureaucracy for a lot of things, but when you're depending on the bureaucracy for your people, then you're in trouble. You've got to think outside of the box and try to think of solutions that are going to take care of your people, because you can't always depend on a bureaucracy to bend in your direction.
Absolutely not. Yeah, I think that geriatricians are really our ally. We've worked with them. I've trained them for almost 18, 19 years now alongside one of our first trainees was my co-fellow. And then we've sort of, he had such a good time and ended up joining UCLA, and we've had a beautiful alliance. And now we have geriatric psychiatrists in our VA clinics. And we learned so much from them. We just had one of our alumni actually on this show, on this virtual support group about a week ago, and just was lovely. We learned so much from her. She's running the Motion Picture Home, which is a big kind of campus of a long-term care kind of facility for some of our folks in Los Angeles. So I think that's a beautiful idea, is to kind of partner with these sort of folks that are, they themselves are quite motivated, I think, to learn more. And so I think we have to get out there. And kudos to you, Mike, for the work that you do. Not only are you understanding more, I think, about the bureaucracy and administration because of your work as a chairman, but I think that leadership role, and when we take on leadership roles, I'm running our Center of Excellence here, you kind of get a bit more savvy about how these things work. I feel like I didn't really understand a lot of these things until I really was in sort of thrust, not by my own choosing, but you know, into the sort of fire. And I think you kind of took over in a similar situation where we're sort of rapidly learning and trying to incorporate ourselves into sort of the framework, but then one can learn some things about how to get things done, I think, from these frameworks, and how to get attention like other people are. It's sometimes a squeaky wheel gets the grease, or I don't know, something like that. So definitely hard work that you're doing. I don't know how you pull it off with all the different hats that you have to wear, but kudos to you. Wanted to segue a little bit into a different universe, and maybe we'll take a couple of questions actually that are just on the chat here. One is a comment. I've already gotten the book. This is from Jill, and finished it. Loved it. Can't wait to start using the ideas to help make people understand what we need to do. You all are amazing. Thank you for your insight. So it sounds like we could drop that into your Amazon comments book section.
Yeah, that's great. Thank you. I actually spoke to Ray Dorsey this week, and you know, because the book came out in the middle of COVID, you know, on March 17th, like right at the height of COVID hitting, it things are stuck. You know, the factories that printed are stuck. It's hard to get out. You know, and you know, the headlines have all been taken up, and so we're going to depend on a grassroots effort. So people like you, Jill, to pick it up and make sure that we're telling that story and getting on Amazon and writing reviews, and all the proceeds go to charity. So our all 4 authors are going to put them to all the Parkinson's charities. So but we do need people to help us to stand up and be charismatic and edgy and pushy and you know, so, but certainly appreciate those comments. Thank you, Jill.
And then there was one question on why don't general practitioners refer their patients who have Parkinson's to a movement disorder specialist?
Yeah, so it's a you know, a perplexing question, right? So why don't general practitioners refer to movement disorder specialists? And I don't want to be egotistical because, you know, we all think that we're important, but I'm not sure that general practitioners even know what a movement disorder specialist is. And when we were looking at web optimization, so one of my night jobs, the PPIN is for the Parkinson's Foundation. So I've been their medical director since 2006. And, you know, in discussions with them about optimization of social media, which really didn't exist much in 2006. And then over the years, it's become such an important part of our lives. When you actually looked at who types into Google movement disorder specialist, it's like 0. I mean, worldwide, like nobody searches for a movement disorder specialist, right? So, you know, so then you say to people, oh, you know, then they send them to a neurologist. Oh, I didn't want movement. I wanted a neuromuscular. I wanted a whatever. It's very confusing, you know, like, so we use all these really confusing terms, even for people that have done 4 years of college, 4 years of medical school, 4 years of residency, they still don't know we exist or what we do or how we're different. So So, you know, as egotistical and as important as we think we are, I think we have to take a step back and eat a little bit of humble pie and realize that people don't, you know, in the real world don't have a lot of time to figure out what a movement disorder specialist is or a Parkinson's specialist. Now, if you have Parkinson's disease and you're invested in your disease, you'll find out really quickly, like who we are and where to find the hero, you know, that has spent that extra time studying. And so, you know, even though we're kind of an endangered species, you know, there's an ability to be able to connect. So I think fundamentally your question is a good one. I think just if you break it down to the base of the problem, I think the crux of the problem is we don't market ourselves right, we don't identify right, and people don't know what we are and what we do. So I think using the term movement disorders neurologist is a little bit worthless, you know, and so they don't know we exist, they don't really care we exist. They want a neurologist to take care of their patient, right, to help. The second issue is this. It's actually not as easy as you would think to identify Parkinson's disease if you don't do it every day, okay? I wouldn't expect, you know, to be able to identify, you know, many skin disorders. I wouldn't be able to expect to identify Crohn's disease or GI diseases. And so why do we expect other doctors to be able to get it right, like right away? But certainly what we need to do a better job of is teaching people that it's okay, like to reach out, like to say, okay, you know, 4 out of 5 people have a tremor. If you have a tremor, like if we could just teach certain things, like don't assume this is benign essential tremor or essential tremor. Don't assume what it is, send it, you know, like, but we don't do that. We kind of have this like ego as physicians, like, oh, we can take care of everything. And we like to know everything. And what we need to do is we need to teach people, when you see somebody shaking, send it, you know, and so that's going to get 4 out of 5 other patients, you know, just simple stuff like that. And then we need to teach them, guess what? If they're walking funny, you know, or not swinging an arm or something like that, they may not have a tremor, 1 out of 5, right? So if we could just get to a few basic building blocks and break down the barriers of communication, and also stop calling ourselves names that nobody understands what we do. Just say, I take care of Parkinson's disease, you know, like shaking, but you know, 1 in 5 people don't shake. You know, if they just knew that, send me your patients, it would be helpful. But it's actually, it's tougher than you would think. So I think it's a great question.
Yeah. And I think we're actually a pretty fun group. I mean, when we get together. So, you know, I think that, you know, people should get to know us a little bit and realize that we're not
I think every group would call themselves the fun group, right? So it's
but I think we don't fit necessarily in the neurology mold of all the other neurological diseases, in other words. So I think we're quite proactive. We want to make a difference. We're sort of, I think there was a sense, at least in my medical school, that the people who went into neurology were kind of, didn't actually have anything to offer their patients. And all they did was spend a lot of time thinking about where the lesion was and what the diagnosis was, and not so much about actually advocating. And now we're talking about proactiveness and aggressively trying to prevent something, which is a very different dialogue, I think, than, you know, some of the things that we may have been known for, I think, in the world of neurology.
I often tell the story that when I was in school, I was a history major, and I wanted to be a teacher. So when I decided to go into medicine, I thought I would carry a black bag and go into rural America, and actually joined a medical school that had that program, the rural America kind of experience. And I probably couldn't have articulated in any clear way the difference between a neurologist and a neurosurgeon, you know, in any very clear, cognizant way that I would be able to pass a test on this. And so it's not like people wake up, you know, like, and they suddenly know these things. And so, you know, if that was me, I think that's probably what a lot of America, you know, is like. And it's up to us to teach people, you know, who we are and what we do. And they used to say in neurology, and I think it was a reasonable criticism, that it was diagnose and adios, right? So we could make the diagnosis, and we were always the smartest people in the class, or at least we thought we were the smartest people in the class. And so, but we could diagnose anything, but we didn't have a lot of treatments. Now it's actually different. Other specialists are taking the diagnosis and adios now, because when it comes to neurological diseases, I can tell you in chairing the department, we have all sorts of cool treatments and infusions and endovascular things, and DBS, and, you know, I mean, just unbelievable treatments for a lot of these diseases. And so, you know, I mean, sometimes we don't reflect back and how far we've come in such a short period of time, but we have actually come, you know, quite a distance in a short period of time in neurology.
Yeah, absolutely. I think we're rebranding a little bit. So
Yeah.
So I wanted to take, there's a quote that I wanted to go through one or two more things that I think are really interesting quotes from this. Maybe we could talk a little bit, and then we can talk about some of the things that people have chatted about here. So one is that in a British survey, you talk about the fact that of caregivers, over 40%, most of them women, reported their health had worsened because of their work. Almost half had elevated depression scores. 2/3 felt their social lives had suffered. In the United States, older people who take care of another adult are 60% more likely to die sooner than non-caregivers. This caregiver piece has been a huge interest of mine, and I think a really unmet, under-recognized kind of thing that we as doctors often spend a lot of time focusing on the patient. Maybe you can speak to some of your thoughts on how to help caregivers, and maybe some of these quotes a little bit as well.
Yeah. So, yeah, thank you for bringing that up. You know, it's a really important issue, and I'll just tell you a little story about this one, because it gets personal for me. So, you know, one of my friends is a pathologist, and he's mentioned in the book, Bob Dean. And Bob's wife had Parkinson's disease, and, you know, it got pretty bad, and she actually tried to hide her disease from, you know, her kids, from people, and that becomes stressful as well, and then also becomes stressful for the caregivers. But she had it for many years, and it got so bad that at some point Bob felt inadequate as a caregiver and as a person in taking care of her, and he took his boat out, and he had a plan that he was going to tie two batteries, you know, like batteries that run the motor. He was going to tie the batteries to his ankles and jump off the side of the boat and drown himself. And he was ready to execute that plan. And his wife got admitted to the hospital and got all this mental health support that she needed to get. And obviously that, you know, that saved his life. It just happened to be on that same day that he was planning to commit suicide. You know, Bob is quoted, and there was a nice national press article about his story about a year ago. But his story is not unique. It's a story that repeats all over America and all over the globe. And it turns out that being a caregiver, a full-time caregiver for someone with a neurodegenerative disease, is really difficult and really consuming. And when our patients are with us, we focus a lot on the patients themselves, but we don't focus on the caregivers. And it turns out that we should probably spend as much time in an interaction with the caregiver as we do with the patient. And I know it's not economically incentivized, and it may sound backwards, but every time I see a Parkinson patient in the clinic, I always ask the caregiver, how are you doing? You know, we're here to support you as much as your spouse or your partner. And, you know, if anything, we know the data suggests that if we can take good care of you as the caregiver or the care partner, that you're both going to do well. And if we don't take care of you and you get stressed and you have a high multidimensional care strain index, which is one of the validated scales of how we measure that. If we don't do that, it's going to be bad news for you. And so it's something that, you know, everybody's always rushing in healthcare, right? You know, they say, oh, can you see me in 10 minutes? And I can't even get a Parkinson patient's meds in 10 minutes, you know? And so, you know, it's the system's backwards, you know, about efficiencies, but we have to do a better job of taking care of our caregivers. And the care partners the better that relationship is, the more strength we give to them, the more they stay out of the emergency room, the more that they're able to care for patients, the more we're able to get the services there, the more meaningful and impactful the lives are. We can decrease fractures and falls. And so it's just super important. And so yeah, thanks for bringing that up. I mean, it's a really poignant issue and a really, really good point.
And, you know, this time of social distancing, I think we really, you know, want to highlight this worry that we have about our caregivers that are maybe on the line, on this virtual support group, or on the phones. We see some people on here, but there's a number of people also just calling in to this. And we want you to take, you know, some time for yourselves if you can. I know that there's been a disruption of possibly your ability to drop off your spouse at a hour exercise class. That might be the only hour of time that you get to yourself. And now you don't have that, or the ability to hire somebody to come into your home to help take care of your spouse, or you know, being able to have a break, you know, with one of your children coming. And those breaks, and, you know, even some of the housework now, some people are not able to bring you know, people into the home to help clean or other things due to this social distancing. And so we really are thinking of you, and just make sure that you take care of yourselves, because it's like that oxygen analogy. If you don't take care of yourself, you won't be able to, you know, take care of others. And we really are worried about you as a population that are out there, and applaud you for all your important work, and hope that you're okay. And if you are feeling isolated and burnt out, you know, make sure that you reach out to somebody, give them a call, a friend, a family member, even if it's on the phone, to be able to sort of connect, because I think that's so key. So really, really great that you talked about that in the book. Another thing that I thought was really interesting, Mike, you talked about the University of Florida Operation House Call launch. And this was something that where I guess you took the Parkinson's fellows and you sent them out into the universe a little bit to see where people live and how they live. Some of these were rural areas, people who lacked maybe insurance and things. And then, you know, can you tell us a little bit about that, and how that affected them, and maybe you as well in turn?
Yeah, so it's a program that we've been engaged with for many years. We first started the program through a collaboration with a foundation called the Smallwood Foundation. And the Smallwood Foundation had some interest in Parkinson's disease, and we've continued this program even now to this day. And so when we train fellows, we usually train 2 or 3 fellows per year. When we train fellows, what we do is we will have every fellow adopt somebody that can't get medical care who has Parkinson out in the community. And they'll have to go out. Some of them might have to travel to, you know, rural areas, and they'll go out and they'll try their best to take care of that person in the home setting. A lot of times these people can't come in, they don't have insurance, they don't have access to care. And over the years, we've even been able to grow this program. So a lot of times they discover what's going on with an individual person, and then, you know, what they do is they're able to choose some of our interdisciplinary faculty, you know, in physical or occupational speech as well, and bring them out with them, you know, talk them into coming out and volunteering some time to see the patients. But once you go into the homes of patients, once you peek inside and you see what's there, you realize just how blind you are as a treating clinician, physician, or whatever specialty that you practice. You're blind. I mean, you can't tell what you're doing and what you're prescribing until you understand the environment of your patient, until you understand the family dynamic, the house dynamic, what their pressures are. And then you understand why people, when you are very paternalistic and you tell them what to do, why they don't do what you ask them to do. And then you learn over time with a Parkinson patient to try to not be paternalistic, to really try to be, you know, as empathetic as you can. And so I always tell my patients, I after the Operation House Call experiences, it kind of molds you and paints some colors for you. And so I always tell my patients, you know, I'm like your cabinet advisor. You know, I'm here to give you advice, but I'm not going to tell you what to do. But this is advice based on a lot of patients that I've seen over the years. Could be right, could be wrong, but whatever you do, the deal is you have to tell me what you do so that I can learn from it. Because sometimes you're going to do something that I don't like, or I don't think is right, and you're going to be right, and that happens. And so, I do think it's important that we have that open level of communication, but the ability to see in somebody's house is really important. And so when they come back with videotapes and, these shocking, like things, did you see this, or how this person lives? And it is eye-opening, and I think it will influence them for the rest of their careers in the way that they practice medicine.
Absolutely. We had Jory Fleischer on a few weeks ago, and she highlighted some of the work that she does with going into people's homes. And again, a lot of information gathered. It's a lot of work. It's a lot of time spent, but sometimes I think eye-opening as it is. And even with telehealth, actually, now that we're doing some videos into people's homes, it's been interesting to sort of see, the background, and people are seeing my background too, and my children sometimes, and what they're doing in the background. So wanted to take a few of these comments. So one is, does it confuse people that it's a neurological disease, but also a movement disorder? Maybe, so that this is sort of the question of, our titles and what it is that we do, maybe, and rebranding it. I mean, maybe it's better if we just say that we're Parkinson's doctors, since much of what we spend our time as movement disorders doctors doing is taking care of Parkinson's. I don't know.
Yeah. And I'll just address that question directly by saying, like, if you go to a dentist, what does a dentist do? They look at your teeth, right? So if you go to a movement specialist, you expect them to look at the movement, right? But the disease isn't just the movement. And in fact, if you look at the studies collectively, not just one, I wouldn't insult you by coming on your program and talking about, one study and one finding, right? So there, study after study after study shows that the non-motor features, depression, anxiety, sleep, affect quality of life more in Parkinson than tremors and the motor features. And so I think we do have to get away from this idea of movement disorders, neurologists, in a lot of ways. I think we're confusing each other, about that. And then people say, oh, neuromuscular movement, I meant to have a neuromuscular doctor, whatever. And, you start to understand it, like why people go down these rabbit holes. We're not even making it clear what we do. And so, as a disease, Parkinson's disease has been described as the most complex disease in medicine, period. When you consider all of the motor and non-motor features over 20, you consider that there's this unbelievable awakening when you take dopamine or apply deep brain stimulation. These ons and offs, there's nothing like this in any other disease. It's really quite fascinating and quite elusive, to understand. And then there's a life cycle of the disease where you can get into motor fluctuations and into all of these different side effects, many of which are quite complex. And so I think it is, arguable, but probably true that this is the most complex disease in medicine. And so it's not just a movement disorder. And in fact, the circuits in the brain that underpin Parkinson's disease are called the basal ganglia. They were defined by a number of outstanding researchers, one of which trained me is Malin DeLong, won the Lasker Award for his really shining light on what the basal ganglia do. But it turns out the basal ganglia are segmented circuits that do motor function. They do something called limbic function, which is behaviors, and they do associative functions, which are called things like cognition and thinking. So the question is a good question. Like, why do we call ourselves movement specialists when majority of the problem is probably not movement? We're acting like dentists, like you see the teeth, you're going to look at the teeth, you're going to look at the mouth. If you see a movement specialist, you're going to look at the movement. You need the movement specialist to look under the hood, of the car to see what's going on. If you just look at the car and you don't put the hood up, probably not going to fix it.
So there's another couple comments. One is something about getting the book through Amazon, which I told you about. It takes a while. So people are getting it on their Kindle or the Kindle.
Yeah, the Kindle, the audio version. So I saw Ray and I talk with the publisher at length about getting the print as big as we could. And it's actually quite, you talk about a negotiation with the bureaucracy of the government, but that's also with the publisher was a bit of a negotiation. So we got the print as big as we can. The print is, you know, I don't know if you can see it. It's not huge. So I mean, I'll just say, like, it's hard to see, but anyway, the print is not huge on the book, but it is one of those things that that we did also lobby to get a really wonderful British guy to do the narration. So there's a very nice audio. You can get a CD or you can get the audio version of the book and listen to it if the print isn't. But we tried hard to get it as big as we could. So
And if you do the Kindle, you can change the font size on the Kindle version.
The Kindle, you can change the font. That's what they told us too. Because you know what Ray and I wanted was we wanted gigantic print on the and they're like, your book's gonna be like 800 pages, doctor. Okay, they're like, well, you can't do that, and so
right. Yeah. And then there's a couple of other comments. So Sydney writes, I've always believed the best gift I can give to my husband is to take care of myself as a care partner. So absolutely. That's the old, you know, one of our advanced practice providers, she tells patients, you know, when you're in the airplane and it gets into trouble, they always say, put the mask on the kid first, or put it on yourself before you put it on your kid, right? You want to help your kid, but you got to help yourself to help others. So absolutely. Then there's another couple of ones. It seems to be a really DIY, so do it yourself, I guess, disease. I was diagnosed in 2012. Neurologist that first diagnosed me said, here's some medicine, see you in a year. There's so much trial and error, and sometimes changing meds is awful. Nobody, including the neurologists I've seen, seems to have any advice about what to use. Is this the norm? And then there's one similar question. We are told this is a very individual disease and it is different for everyone, but I feel like we are all put in the same box and treated the same. This angers me. Yeah. I mean, I think those are, you know, totally fair level criticisms at our healthcare system. You know, the other complicating factor is your insurance carriers, right? So now, you know, people are told who they can see or who they can't see, depending on which network that you're in. And some of the networks are better. Like, for example, you're in California. I think the Kaiser network carries a lot of Parkinson specialists within their choices. But other networks and other insurance companies, they may force you to see a certain person or to see a triage person before you get, you know, to the right individual. I mean, I will say this. I think that we have to stop getting mad at each other for asking for second opinions. You know, so I can't tell you how many times people come and they say, oh, I'm seeing you, but don't tell my doctor, you know, like, you know, don't tell him, you know, don't tell her, he's going to be pissed. Well, you know, let them be pissed, because I think that when we live in a world where we can't communicate with each other and we can't talk in an open way, it's not good for the patients. And so even in our interdisciplinary meetings, you know, when I'm explaining how deep brain stimulation works, I explained you're going to see 7 or 8 or 9 different people over 2 days. We're going to screen you, and then we're going to talk behind your back. And people go, oh, talk behind our back. And I say, no, wait a minute. It's not what I mean. I mean, we're going to talk behind your back, because if people are talking behind your back in healthcare, that's the highest level of healthcare that you can hope for. When a group of people that are trying to take care of you are actually talking together about you. And then, of course, hopefully they'll communicate the message back to you. What we're doing a very poor job of is saying, okay, I'm at my doctor. I don't like my doctor. You know, can I get to another doctor? Will I be allowed to get to another doctor? You know, and can I get to the right doctor? And it's kind of like a match. It's kind of like getting married. You gotta find somebody that you can trust. And with the, you know, the endangered species of the Parkinson neurologist or the movement neurologist or whatever you call it, I would say it's probably better to call them Parkinson neurologists. But even a good neurologist that's experienced, that cares about you, that will listen to you, could be better than a fully trained Parkinson neurologist, you know? So, you know, you just want somebody that's going to care about you, be invested, and be open to trying some new things and listening to, you know, what are the features that ail you, because Parkinson is a dynamic disease. So each time you go in, you know, there are different things, and it's really important to key in and listen to what the patients are saying, because it's usually
without exception, what the patients tell us that helps us to make the changes. And so we actually have to listen to you. So if we're not listening to you, then you can't effectively treat Parkinson's disease. So I'm sorry you've had that experience, but we tell people we have a free 1-800 line at the Parkinson's Foundation, 1-800, the number 4PD-INFO, 1-800-4PD-INFO. And it's staffed by nurses, and they'll answer your questions. And if they can't answer the questions, usually they'll email me or give me a quick call. And they're awesome, you know, and they help people find other practitioners. They help people with their questions, and it's very nice. But it's a problem. It's a problem. I'm not going to sugarcoat it.
Yeah, so I think, again, leading back to the advocacy organizations, including, you know, the Parkinson's Foundation, there's many, the PMD Alliance has been amazing to host this type of thing too, and also have a lot of resources. So a couple of other comments. So Munal Subedi from Nepal. I am a young onset Parkinson's disease, onset about 6 years ago. I opened an association for Nepalese Parkinson's disease and a fitness center, which sounds amazing. Thank you, Dr. Okun, for donating some books in our association. That's amazing. And then
we'll be mailing those, by the way. We're held up a little bit with the corona, but I have it on my list, so you can blame me for being a little behind, but I do have your books for you.
So cool that we have such an international representation in our chat today. So lovely. And then there's been a question or two about getting involved in research, and I just wanted to say that you sort of described this service and science hub at your institution, which sounds amazing. And I think many of us are lucky enough to work in places where we offer multidisciplinary care, yours and ours at the VA in West Los Angeles. And there are states where there's literally, I think somebody was saying there's no Parkinson's neurologist in Montana at all, or anyone that really knows about Parkinson's. So I think it's so different depending on where in the world, where in the country you happen to work. Some of the statistics on neurology to patient ratios in Africa, yes, I think that you list is quite stunning. So I think anything that you can do to empower yourself with knowledge, reading a book like yours, getting knowledge through these patient support groups is just so key. So I think we're, yes, somebody asked if it'll be available for playback. We want this video shared widely in all of the videos that we've been doing. We have about 10 of them in the series. Boss Blom will be coming up as well. Many, many other questions. I don't know if you want to spend maybe the last couple of minutes just giving a wrap up and maybe something about the Research Hub sort of and how patients can get involved with research in their journey?
Sure. So when we came to the University of Florida in 2002, kind of our dream was we were going to build this thing. It was Kelly Foote and myself. Kelly Foote's a neurosurgeon, and we've been friends now for a few decades. And so we kind of went into this as friends, and you know, we just kept building with this idea that we were going to build into this interdisciplinary center where we could have all the specialists. I mean, we said, wouldn't it be cool if your mom had Parkinson's disease and she could come in and see everybody under one roof and get access to research? I mean, it seems pretty like a simple concept, but it actually took quite a bit to put that together. And when we published on it in JAMA Neurology, you know, we called it the Service and Science Hub. And the idea was creating a place that's all under one roof where, you know, patients are not, you know, most patients are lucky to see one person, you know, one healthcare provider, whether it's a PT or a OT or a doctor in a day. But imagine you can see 7 or 8 providers if you need to and get access to hundreds of research studies all under the same roof. And we have mini labs, and the patients, you know, they paint the art and they compete for the art on the walls, and we create healing spaces inside and outside for our patients. We have indoor and outdoor rehab. And so we've really built what I think is kind of a state-of-the-art dream, but it's like I always say my life is like a beta test. You know, like every day I wake up and we try something and then we don't like it and we try something else. And so we just keep building and trying to make it better and better. And so I think that, you know, when you talk about distributed systems of what's the best way to take care of Parkinson patients, and then also get them involved in research and access to research, and the hope research is like a synonym for hope, right? Like that you hope that the research is going to be what's going to drive the next generation. And we have a generation of Parkinson patients now, and I always compare them to the picture of the man standing on top of the globe or the woman standing on top of the globe looking at their watch, you know, and saying, you know, got to hurry up. I mean, it matters. The time matters for people that are suffering with various diseases. And so creating these sorts of things, we call ours a service and science hub, you know, where you can get the science and the service all in one place. And we have a simple philosophy that we've had since the day we opened on July 1st, 2002, which is patient's the sun, and we should all, you know, orbit around the patient. That's it, no matter who you are. So nobody's more important than anyone. And so we've kept that philosophy with us. We repeat it all the time. And it's important, I think, to have a philosophy that you live by. Boss Bloom has a wonderful program called the NET PD program or PDNet that's all over the Netherlands. And so there are various versions of this. And I think that we have to start to think bigger about the C. So remember, it's prevent, advocate, care, and treat, and develop new treatments. We have to think bigger about how we're going to get the care to the people that need it, not just, you know, these, you know, groundbreaking breakthrough discoveries. It's more than that. And so there's a piece of this that's really important with any disease. And so as you go on that journey for ending Parkinson or whatever the Mad Lib is for the disease, I think you have to figure out, you know, what are going to be these systems. And I'm not saying the system at the University of Florida is the best necessarily, but it's pretty darn good, you know, and it serves our patients pretty well on the patients that travel to see us. So we don't desire to hog the system or, you know, just, you know, be the only person with a system like this. We need to create, you know, some equity, and we need to drive research and to show people different ways that we can do it so we can build these systems all over the place. I mean, with the number of people with Parkinson's disease, we should be training, you know, a log number of more specialists, not just physicians, but physical therapists, occupational therapists, speech therapists, nutritionists. We should be training all of these people, and we should be developing these centers everywhere that we can. We shouldn't be competing with each other. And I know the other dirty secret of my job in the Parkinson's Foundation since 05 or 06 is breaking up fights, you know, which is always fun when you have two nerdy neurologists fighting, or three nerdy neurologists fighting over patients or something. And it turns out that you way outnumber us as Parkinson patients. Those fights are so easy to break up, you know, like you can build as many of these things as you want, and we can't exceed the demand, particularly with the growth of this disease. So I'll leave you with that thought, and it's been a pleasure and honor to be with you all today.
Thank you so much. Well, thank you for being our all advocate and, you know, riding, you know, at the front of this charge to try to end Parkinson's. And we hope that, you know, we've brought you some information here, and Mike will put up some resources, and hopefully everyone will read the book and put some comments on Amazon. And again, I think there's, you know, a lot of work to be done, tons of patients to be helped, so many people to be educated also who are trying to, you know, help provide this care. And so we'll try to work together to do that. And PMD Alliance, thank you for hosting this. I'll hand it back to you, Andrea, for a last maybe wave goodbye with all of our folks on the.
Thank you, Dr. Okun. Thank you, Dr. Subramanian. Everyone who registered, will send out a link. I've also put it in the chat where you can find the series overview. Next Thursday, we're going to be talking to Dr. Boss Bloom, so can hear about, you know, Parkinson Net and some of the things you referenced, Dr. Okun. And then on Friday, the 24th, we're going to be talking to Tanya Simuni from Northwestern. So we only have the heavy hitters on this show. So stay tuned. We hope to have you back next week, noon Pacific. Make a date in your calendar for us. And again, thank you to our speakers. Thank you to everyone who joined in. And let's wave goodbye on behalf of PMD Alliance. Thanks, everyone. Have a great weekend, too.
Bye-bye.